I'm here with Renato Ambrosio. We're going to be talking about risky corneas. What constitutes a risky cornea, Renato?
We should understand that the risky cornea is not the same as keratoconus. We are seeking for detecting the very subtle characteristics of the cornea that are similar to what we say is a form-fruit keratoconus, and I prefer to say is a susceptible for progressing ectasia. But eventually, if you look at the perspective of a weakening procedure that we can get, every cornea is a risky cornea. Every cornea may undergo ectasia if you do a cut very deep or if you ablate very much of tissue to have a thin residual stromal bed. So the issue is having a risky cornea in a complex of what the patient has preoperatively and what you're going to do with the laser vision correction so that the cornea is stable. So you should look at how you're going to treat that cornea so that you can improve the sensitivity to detect the patients that are not candidates because they are at very high risk for refractive surgery-induced ectasia, but also to get the benefit of the surgery for the ones that may benefit and eventually change the procedure so that you can do some surgery to help those patients for getting refractive surgery even though they are at risk for having ectasia.
As you know, a form-fruit keratoconus is number one common, and number two, it's a spectrum. I mean, there are patients who are more form-fruit and more keratoconus-like. So, where do you draw the line? I mean, how do you determine who you're going to treat and who you're just going to counsel?
That's a great question. If you look at what is form-fruit keratoconus, Mark Emsler, Professor Emsler described that probably 50 years before topography was invented. He described it an abortive form of the disease that may progress or not. So eventually those patients that have form-fruit today that we are looking at, we have subgroups of populations, like the patient has one eye with a normal topography and the other eye has a clear keratoconus. They are not unilateral. They are asymmetric keratoconus with a form-fruit in the normal topography looking eye. This is one of the subgroups that we look at, and we know that the topography is not abnormal. Eventually, if you try to look at it with a very sensitive scale, like a 0.25 normative scale, you always find abnormalities, but the sensitivity will be very high with a sacrifice of specificity. Going beyond topography, not over it, we go to tomography, and we have to look at objective validated parameters. Going back to topography, we did a study that is just impressed in the JRS. Isaac Ramos helped us to combine a series of experts that will classify 25 topographies. The classification varies a lot from one to the other, and if I give you the same topography with a different scale 6 months later, more than half of the experts have a different classification, statistically different classification. So we need to get validated objective parameters, not only on topography but even tomography, because if you see the old orb scan, you see this is very abnormal, this posterior float, but what is abnormal for you today may be not abnormal for you tomorrow, depending on your mood. So we need to get tomographic parameters that are validated and specifically designed to get accurate findings so that you're not changing your mood, you're changing your analysis.
So in the context of your own practice, how do you manage patients coming in?
First of all, I do topography in every patient. Because of the dry eye, it's enough of a reason for doing front surface reflection topography with a placido. But tomography is the way we have to go to understand the cornea if you can or not challenge the cornea with a refractive procedure. We designed the Bell and Ambrosio display with a pentacam, and we have two parameters that are very objective, the Bell and Ambrosio D and the Art Max. Those are the numbers that I have to, the first thing I look at after looking at the curvature map is those two numbers. And the thresholds for normals versus keratoconus, they are different than the thresholds for the normals versus the form-fruits. So we have to understand that. We just recently got the information that age adds to those parameters. So if we just use age as a factor along with the D, you have a much more robust way of detecting the ectasia patients. So looking at a population that had ectasia after LASIK, which we have the preoperative pentacam, we got a regression analysis that age was definitely very, very powerful to add to Bell and Ambrosio D. So we can back calculate the risk and say for every patient that we examine based on age and the D, only those two parameters, we can calculate the residual stromal bed that will be safe for that patient.
I understand. That's really interesting.
So we are developing a score, is a ectasia susceptibility score that we are designing just based on two parameters, just two parameters that is very validated. If you just look at age, you say that nobody under 30 years old cannot have LASIK. What's the specificity of that? I think goes to show. Most of the patients that can benefit from surgery that are younger than 30 years old, they wouldn't benefit. So you have to be specific to say, yes, you can do surgery, and sensitive to say, no, that surgery is risky for you. And eventually, with phakic IOLs, you can get benefit from the procedure. Eventually also surface ablation. Of course, those patients that have disease, they need to understand that they have a disease, and refractive surgery may accelerate the process, and they have to understand if they are going to do or not a procedure that is not therapeutic, is elective for those, eventually with cross-linking, for example.
That's a great point. Thank you very much for spending time with us today, Renato.
It was my pleasure.